Finding the market gaps. Mitch, let's start with you. I mean, let's just hear how you found your market gap, and let's hear about what you think the market gaps are at this point.
Sure. So obviously this forum is about the healthcare business in flux, and what we see is that much of the decision-making and responsibility is being pushed down to the consumer, who's also been known as the member or the patient or the employee. And consumers are paying for a greater percentage of their health care. They are starting to pick their own insurance through the public and private exchanges. They are now having a greater variety of providers from which to choose. And so you have a consumer that's now making more decisions in an area where there's really not a lot of information resources. And in an era of the web, when we have reinvented the way we buy everything from travel to cars to electronics and books, we need to reinvent the way people buy doctors and healthcare providers based on information. It's what we do at Vitals, and there's a huge market gap because you have lots of decisions that need to be made by people that need to get a lot more information to make them intelligently.
So you're saying there's a market imperfection here, that somehow market forces have not delivered what they should have delivered to patients particularly, and has been some sort of information asymmetry here going on that's quite fundamental.
Yes, and the word market forces is an interesting one because typically the health care business has not been driven by market forces. It's been driven by other factors in terms of where care is provided and which providers end up getting the patients. And so once you bring a consumer into the mix who's spending their own dollars with high deductible plans on a variety of treatments, because there's all these new imaging centers, infusion centers, freestanding surgical centers that are alternative ways to get treatment. Once you bring that in and consumers can decide based on information, that's when market forces start to play. People are going to be choosing higher quality, lower cost providers. That requires information to be able to understand who it is, and there's a huge gap in being able to define that for the consumer and help direct that choice in an intelligent way. Think of all the companies that have grown up in, whether it's Travelocity or Orbitz or TripAdvisor or Kelly's Blue Book or others in the world of the web that have been providers of information to allow people to make intelligent choices. That's what we see as really a big gap needing to be filled.
In fact, I mean, most of the gap that we're talking about today is being filled by data and information providers. And Niven, I want to just pass on to you and just sort of ask the question right out there. Do you think technology in this sense, in the data sense, in the bringing together of data, is going to really reduce the burden and create a more efficient landscape in healthcare?
Yeah, I think we absolutely have an opportunity to use technology and to integrate the various stakeholders within health. I think that one thing, we always hear about this term big data, and it's really sexy, but it truly is only a lot of data. I mean, big data means lots of data. So I'm actually not a big fan of the term anymore, but what we really need to get to in healthcare is to arrive at a place where we have actionable data to all the key stakeholders in the payers, the providers, the physicians, the hospital systems, pharmaceutical companies, the governments, but most importantly the patient. Because the patient has become such an important, critical role in the overall ecosystem of this data capture. And as we can and secondly, we need to model off of biology. We are modeling the entire healthcare system off of historical algorithms, historical data sets, spending, outcome, etc. What we really need to do is think about what's ongoing in ourselves, in our own biology, and use this biological data that understand and go much beyond genomics. Genomics is a start. But we need to look at the environments. You have two women who were diagnosed with the same type of breast cancer in Boston, one's in San Francisco or London, for example. Same diagnoses, same genomics, same type of disease, but with completely different outcomes. They used the same drugs. And why is that? Because we're not taking the time to fundamentally understand what is in that patient's microenvironment, their demographics, their stress levels, their overall impacting factors of that patient that's driving the outcome. And if we can get to a point, and the good news is that we actually have the technologies now to do that. And it's not, well, we have to go and develop it as 5-10 years ago, away, I'm sorry. It's here today. So if we can use the combination of using, for example, artificial intelligence, Bayesian algorithms to take this inputs of data and integrate the data sets from the patient biology, the clinical outcome, the demographics, all the other models that impact the ecosystem, we have a real chance of understanding how to economically model healthcare. So health analytics will drive a more sustainable health economic platform.
So Niven, the sense that big data is still not providing actionable endpoints at this point in time. How, I mean, what are we going to be doing to ensure that somehow that universe of data is going to be providing, it's going to be reliable enough, it's going to be deep enough, it's going to be broad enough to be able to provide actionable data? What are the next steps for that?
So for the first time, you actually see this fusion that's ongoing now in government at the, let's just take the U.S. for example, at the NIH, at the Department of Defense, even the CDC with this whole Ebola event. You better believe they're using a big data approach to understand where the hot spots are happening in the Ebola virus. So that's a real live example of how this can be used to map not only the Ebola virus, but the overall population as a whole. So government is employing these types of approaches. The leading universities and academic centers are doing that. And now, finally the biopharma and large pharmaceutical companies are now enacting these big data. Again, I don't like the term, but that's what they call it. A big data approach. So now you have the academics, the stakeholders in government and in industry coming together to form these alliances to say, okay, before we even start to develop drugs, let's understand the patients first. Because the current model is we develop the drug, we test it in patients, we get it on the market, and then we figure out what happens on the biology. And certain patients have toxic events, in some patients the drug doesn't work, in some patients it does work. If we can triage that endpoint of the point of care of healthcare and flip that model to the forefront, we're going to be able to do much better in healthcare and not spend 18% of the GDP on healthcare.
I want to come back to a couple of the points you raised, but Mitch, can I just, before I come to you, Walter, Mitch, can I just sort of ask you about this sense that actionable data is still some way off, even though we can put together lots of that data in ways which are intelligible and helpful to patients? There is still quite a lot that we need to do.
No, I would disagree with that statement. Okay. I think that the data is here and the data is very usable. Let's take a couple of examples. Any of us, when we get a bill from a hospital or a doctor and we open up that envelope with the bill, we have almost no idea what that charge is going to be in the United States, whether it's going to be $20 or $400. We are ignorant about what the cost of that care is until well after it's done. That is knowable data that can be known beforehand, and we do our shopping without that data. So the simple act of bringing the cost information from post-treatment to pre-treatment now gives people an understanding of what the different price information is. Similarly, having to do with doctor quality. There's a lot of information about the better and worse providers out there. It's only now being exposed to consumers, and the magic of the web is making that available. We've got on Vitals over 5 million patient ratings. When you go into a waiting room, the protocol is you sit there, you don't talk to anybody else, you're not getting the wisdom of crowds. We use the web to get the wisdom of crowds. So the data is there, it has been collected, and I think it's just now starting to get actionable. What's happened is that the consumer, who's now becoming more empowered, is just not used to using that data yet. But I believe the data is there to be used.
Walter, what was the gap, before we come back to some of these very interesting issues, what was the gap that motivated the launch of your foundation?
So, Charles, first of all, I want to just say that extremely excited to be here. It's fantastic to have the opportunity, and the Economist it deserves great credit for putting on this kind of panel in this entire day, and the forum itself, addressing the most critical issues that we're facing in terms of gaps. And I'll also just want to side note, long-time fan of the Economist, back when I couldn't even afford it in high school and college, and it's for me coming full circle to be here. So still can't really afford it being at a foundation, but doing the best we can. But I did want to thank you for the question. I think we are in an amazing time right now. The transformation that's happening in healthcare, in the United States, around the world, to address some of the issues that both Mitch and Niven just raised is unprecedented. We would never expect to have been at this point in time. In terms of our foundation, and in cancer in general, it's an amazingly transformational time as well. Never before have we understood so much about the science and the biology of different diseases, cancer included, myeloma in particular. Never before have we had the kind of technology available. Mitch mentioned some of the imaging, and obviously Niven mentioned some of the fundamental sequencing and molecular and omics data that's available. And never before have we had the communications platforms that exist today to convey this information, to collect the information, and to communicate between the entities that Niven mentioned, the researchers, the doctors, and the patients. And at the end of the day, all this is great, but it does nothing unless we're driving cures for patients, or we're improving their quality of life. And the gap that started our foundation was exactly the one, almost to the person that Niven just mentioned, a woman, Kathy Giusti, who had a terminal diagnosis of the second most common blood cancer, but was told to put her affairs in order. She had 3 years to live. And that was in 1998. That was not acceptable to her, being a Harvard, in Boston. I have to mention she's a Harvard Business School grad, and being a pharmaceutical exec. So many of our audience comprise the industry members. That fundamental facet, that there was the same drugs available to treat her as treated her grandfather, and that was her prospect, was unacceptable. Yeah. So something had to change. There had to be a disruptive force to make that change happen. So many of the models that we're talking about today are basically reminiscent of what the foundation really poised and premised itself to begin with, to fundamentally disrupt the drug development and research process to drive cures of patients immediately. We can't wait a decade or 2 decades to do that. So the facets that we're fundamentally addressing and able to do now, 15 years after founding the foundation, address some of the gaps we're talking about today. Between data is great, but unless it's knowledge that's actionable, as Niven just mentioned, it's useless. The gap between access. It's great to go to a doctor or a clinician, but unless you're getting the care that's personalized to you, that's going to address the particular issues that you have in your type or subtype of disease, it's not really useful to you, and it's a waste of the point that Mitch was raising earlier, money. Yeah. And most importantly, the patient needs, right? And everyone has specific issues they're facing. The gap between their needs and a cure is the most fundamental gap that we are focused on. So the foundation itself has committed its full weight and power to transforming our particular area, but using the same models that we use to transform our area to cancer overall and what we're talking about today. It is engaging actively and productively in ways we never have before, the government agencies and regulators that determine what drugs get to patients. So FDA, NCI, NIH, they've got the big pockets. I mean, all of our tax dollars at the end of the day end up as a portion there. The industry members who have fascinating and tremendous researchers, but unless they're focused and brought together in ways that they don't normally collaborate because of their own intentions, they're not going to be productive. The academic centers are fantastic fonts. They drive much of the research forward, but they too operate in silos. At the end of the day, it's the patients for whom and about whom that they exist, right? So unless that focus is turned around, as Niven was saying, to address that fundamental need that patients have to drive to cure, nothing will happen. So by bringing all these entities together, by doing it productively, and a patient-centered approach that basically empowered patients, that's the models that we're putting in place, from putting unprecedented data, clinical and genomic, together out into the public domain for all researchers around the world to access freely. It's a disruptive concept. Academic centers aren't doing it. Government's barely doing it. So that's one dimension. That's addressing the data, to knowledge gap that we believe exists. The second, in terms of rapidly progressing discovery into cures, is the second dimension that we're absolutely focused on. And that facet of the science, the technology, and the ability to communicate and convey information or collect it is what's transformative. It's what helped us address HIV 20 years ago, where a death sentence was basically the moniker of an indication you have HIV, to actually have that transform. New classes of drugs that were brought in just about a year or two after a diagnostic test to detect viral load, and the information dissemination that patients could actually be treated. That is the same transformation that we're seeing in myeloma today and in many cancers today. And that's what makes me believe that in 3 to 5 years we're talking about cures, not just where to go for care. So that facet of rapidly evolving and turning discovery into products that we work so intimately with industry and academia and the government to do is absolutely critical. And I think the third dimension is the decentralization of care. It used to be when we were sick, and maybe I have vague memories of this, a doctor would actually come to your house and see what was wrong with you and take care of you. That pendulum has swung to the opposite end, where we all go to clinics and centers that are more specialized. And if you have a disease, whether it's a rare infectious disease like Ebola or a cardiovascular disease, you go to a clinic or a center or a hospital. Well, we're rapidly seeing that with the Healthcare Reform Act and the Affordable Care Act. That is being disseminated and broken down. So decentralization of care back out to patients themselves in their own homes. The Apple launch of the Health Kit last week, where you can use monitors on your wristwatch to actually measure and determine how you're doing, whether it's diabetes or actually cancer. That decentralization is also happening. And underlying all of that are these platforms just talked about. So that's the kind of way, those are the ways in which the foundation is working to break those gaps, but we're working with all the entities that were just mentioned.
Mitch.
Yeah, I'll echo that, but with a slightly different take on it. From the data and knowledge side. I think that the one tremendous innovation of the last 15 years that doesn't get enough credit is the FedEx tracking box that you can now do on the web, where people can type in the package that they've got and be able to track the FedEx package. 15 years ago, there were banks of phone operators who you would call up and get that information. That information was kept inside the FedEx system, and FedEx decided revolutionarily to turn that out. And we've kind of seen the whole idea of proprietary data being turned out and being accessed by the public, which allows it to be much more efficiently used. In coming up here, I could pick my seat on an airline on the web. That was not something anybody could do 15 years ago. There were algorithms that were taking care of that. And I think it's only now in the world of healthcare that that mind shift that says this data is private, we won't share it, it's proprietary, whether it's cost data at the health plan or quality data at the surgical level, and the idea that we're going to now push it out and make it available to public, that is revolutionary and creates a lot of opportunity where there's gaps for utilizing that data that just was not there before.
Well, can I pass that thought on to you, Niven, and just ask this question about data governance, because that's clearly an issue in here, opening data out, getting open systems of data. To what extent, is there a challenge around data governance, do you feel?
I think in the past 3 to 5 years, there's been a lot of policy. Since HIPAA has come out, it's really given that the patient the real power to govern what happens with the collection of his or her data, but also with the dissemination, as you say, Mitch. So there's more of an understanding now through institutional IRBs, to collect a patient, even if it's a tissue sample or a patient's serum, a blood sample, it needs to be done in a manner that respects the HIPAA process, but also every institution around the world for clinical research, as dictated by the WHO, needs to be collected with the constraints and in individual jurisdictions with the permission and the approval of the ethics boards, but also from that patient consent. So once that's in place, now there are algorithms that can then anonymize even. So step one is collection and consent, and step two is processing of that data, and step three is how do you disseminate that. In the dissemination, really now we're at a stage where we can anonymize data, so it's not as much of an issue it was even 2 or 3 years ago, I would say. So data governance, even in a meta-analysis per se, can be done in a manner that allows the stakeholder, for example, the pharma company or the government, to see what's ongoing in a global population without getting so specific that you're putting at risk the actual patient data. So I think that's not as much of an issue, and it's continually being looked at how you can enhance that. But I did want to touch on number two of what Walter spoke at, drug development, because on average it takes 12 to 14 years and $1.7 billion to create a drug. And if you think about that, the innovation so in our current model, the innovation on average is saying that if a patient gets diagnosed with, say, a certain cancer, a myeloma, 2014, potentially a treatment, and the key word here is potentially, a treatment out of all the processes it has to go through, is going to come in 2027. I mean, that's not acceptable.
Not in myeloma.
Yeah,
okay.
well, not in myeloma, but in triple-negative breast cancer. I mean, there's in pancreatic cancer and in glioblastomas. There's all these clinical unmet needs. And I think this fusion of biology and technology allows us to now really firmly flip the model and put the patient data at the forefront. So because we're getting better as a whole at innovating and understanding with the omics and artificial intelligence, et cetera. But the clinical trial process, it's still what it is. So if we can get to a precision medicine approach to being able to test the right drugs in the right patient population and select them way up front, we're going to be much more efficient in the clinical trial process, but able to work with regulators like the FDA, EMEA, et cetera. So it can't be that, we do the trial and then we come back with the data with you. I think it needs to be a continual open conversation with foundations, with the FDA, et cetera, to say, here's the population we're going to focus on. Here's why we're going to focus on that population, because the biology is a better fit. So that as we then get into phase 2, phase 3 trials, we're doing so in a much more effective and most importantly, a cost-effective manner. So instead of 12 to 14 years, we can look at, it should be a goal to cut that in half.
Walter, accelerating this process is really fundamentally part of this, isn't it? Patients can't wait for cures, can they?
So, and your points are so important, Niven, because, and I think the best part of what we're seeing is that all the entities that we're talking about, from government to industry to academia, are beginning to and having to, because of many of the financial and reimbursement facets fundamentally changing under the feet, having to look at how to reconstruct, or basically deconstruct what they're currently doing from this big monolith, like you're just describing. Sequential phase 1, phase 2, phase 3, submission. Hopefully, it gets approved to get to your 15 years and 1.7 billion, to one where we're talking about like 3 to 5 years. I mean, if you go back to not just the HIV example, but even we're talking about Ebola today or myeloma itself, we're looking at by integrating and leveraging this convergence between science, technology, and the communications of a patient and research integration, moving to that 3 to 5 year model of identifying activity in a bench, validating it quickly in a collaborative consortium basis, moving that into patients, and then testing it in an enriched and stratified way among people who are most likely to benefit from it, and test if it's positive or not, and then rapidly expanding that cohort to approval. The FDA has helped to break down this monolith. Breakthrough status nomination by Janet Woodcock, Peggy Hambrick. They have changed how drug companies are now looking at how they approve drugs. Those companies are somewhat scrambling to say, well, how do we do a targeted therapy for one mutation, or whether it's a biological one or an infectious one, that's going to be profitable for us? Well, the answer is, someone go back a little bit in time, and you're going to have combinations of drugs that are going to be necessary. And the FDA is asking us, test these in combination, do it early on, demonstrate individual dose efficacy, and then move it forward quickly. But do it quickly. And that's exactly what we're looking for, because the unmet need is improvement in life, in quality of life, and improvement to drive to cure. So with those pieces in place and the willingness there, the money is now the key issue helping to drive some of this transformational change. And there's no lack of good ideas, but there's got to be some focus with regard to identifying those facets that can help that kind of change happen. Identify those companies willing to take the risk, those entrepreneurial entities, whether it's in a foundation, whether it's in the companies, or in some of the institutions that are saying, you know, we can probably do without the monolithic or the one-size-fits-all approach. Let's try something different and make it happen. And that's how you're seeing transformational change. That's how we've gotten, you know, patients living up to a decade now in myeloma because of 6 drugs getting approved in a time it usually takes just 1. And we know if we can do it in our area, where we're an orphan disease, it's absolutely translatable to other major disease areas. Yeah,
and I think just to add one more thing to that is most drugs that are on the market right now are based on chemical compounds. One other provocative thing, at least that we're doing at Berg, is you find a target, you screen 500,000 chemical compounds, see which ones fit, and then you carry that drug forward. We've cut that process completely out of the picture. Once we find the phenotype or through omics and the AI that we perform, once we find the hot spots in the biology that are the difference between disease and health, the internal peptides and proteins and enzymes, those become the drugs. So there's no chemical screening. So that process right there on average is 3 to 5 years and from $50 to $150 million. So those are the types of stopgap measures in addition, that are leading to extra time and cost and the one size fits all. Because I completely agree with you. I think that if we could find in cancers, in diabetes, in neurology especially, in the CNS disease space, we don't even understand the biology. We have to go back and start from scratch to even, Alzheimer's, Parkinson's. We're at the Economist. When you look at the aging populations, 10,000 Americans are going to retire every month for the next 10 years. Think about those numbers. So I think from the Pew Institute, 37 million Americans are going to retire. So age-related diseases. So we think we have a burden on healthcare in 2014. The fusion on health outcome is about to come actually in the next 10 to 15 years. So we're going to have more of an aging population. We have neurodevelopment diseases like autism, early onset in type 2 diabetes in teenagers. So it used to be that if from 10 to about 50 overall, folks were fairly healthy. That paradigm's gone. The reality is that across the age spectrum in the developed world, we have major diseases now. And if we don't capture the biology and capture an understanding to identify where is that risk, how can we get to these patients earlier and work with the insurers, for example. Work with insurance companies to say, I cover 10 million people. A lot of, 20 to 30% of the patients I cover lead to about 60 to 80% of my cost. How can I identify those folks early on? So at pre-hypertension, at pre-diabetes, and like the programs that you guys are working on, Mitch, that's at the forefront. You then are at the forefront to work with the consumer to say on your iPads, on your iPhones, taking all your metrics every day and shooting that up into a cloud that goes to your doctor, that goes to the hospital system, that goes to your insurer to say, oh my God, in this patient profile, the hotspot is starting to occur. So we can triage that much earlier, through some of the work that your company is working on. So I think overall, the ability to tackle the problems exists. We just need to talk to each other.
Do you want a thought there? Or? That was a nice...
I think you said it well.
Perfect. I wonder, this is a fascinating area and so fundamental and important. I wonder if there are questions or thoughts from our audience for these 3 panelists. Here, down here, if you could just mention your name, please.
My name is Michael. I'm with iVantage Health Analytics, and we play around with some big data ourselves. And I'm with you regarding that term, and it's a buzzword and all of that. I'm curious to get your feedback, all 3 of you, about making that data accessible. I feel like it's siloed in various places. When we get a hold of it, we're awful glad we have it, and we want to make use of it. But one of the challenges we see is providers and private data, patient-protected data, claims data. If we could put all this together, we know what innovators could do with it. And Data Palooza and some of the things the government is hosting to try and really begin to make this data accessible, that's wonderful. But in my experience, we're not quite there yet. And so I just would be curious to get some feedback.
Yeah,
I'll put the data together. Yeah.
I'll get started with that. I've heard it said that, with all due apologies to The Economist, that the 20th century enriched content creators and the 21st century enriches content aggregators, whether it be Google or Facebook or others. The whole idea of aggregating of this data that exists in silos is going on now. That's basically what we do at Vitals. And for whatever reason, the healthcare system had been historically very balkanized. You can find costs from the insurance company and quality from rating organizations and appointment times from the practice management system. And that is getting all stitched together. The reduction of friction in the system by companies like ours at Vitals and a few others is clearly there. As I said early on in my introductory remarks, the consumer isn't ready, I think, yet, by and large, for the complicated ways that information has to synthesize. People just sort of want to know, tell me the best doctor at the best price or the best hospital, or where am I going to pay more or less for what I need getting done. I mean, take flu shots as one example, where there's been a huge migration from the doctor's office to Walgreens for that. So that work is going on. As I've said, the barriers are breaking down, and a lot of it is functionally the willingness of the owners of that data to let it go. There's a panel this afternoon called Price Transparency. Transparency is a good word when it comes to things like this, and one of the panelists is from one of our biggest customers, Healthcare Service Corporation, a large Blue Cross plan, and they have been very willing to put the cost data out in front of the consumer so a consumer can decide between a provider that costs $500 or $700 or $800 in out-of-pocket. So it's a combination of the data getting aggregated from the places by guys like us and the owners of the data being willing to release it on a appropriate basis, and that is very much happening now. And I'd say by 5 years from now, we're going to think it was madness to not know what it costs to see a doctor before you go, not know what patient ratings were, and all those kind of behaviors that were that today we view as normal.
Niven, can I ask you, how are you addressing this question of the balkanization of data? I mean, particularly given that you're trying to go beyond the biology in a sense and aggregate all sorts of other environmental data in there as well. How are you going beyond this balkanization?
I think through some amazing partners that we have. We're partnered with the Department of Defense specifically to look on prostate cancer. We're going to expand out that relationship. But if you can, like you guys have a really focused effort on multiple myeloma, and you've done a fantastic job at bringing this now, like you said, 4 approvals in the past 5 to 7 years. So it needs to be stratified in a manner that it's extremely focused. So when we deal with DOD on prostate cancer, the data is governed in a manner where you have endpoints in diagnosing, prognosing the cancer through the right types of diagnostics, looking at the next generation of drug targets, looking at the existing drugs that are out there to find which non-obvious combination of drugs may work best. Because we're seeing all this metadata on studies that pretty provocative data out there to show blood pressure pills and metformin, for example, potentially having effects on cancer. So there are drugs out there that are already approved. If it can be repositioned in a manner that affects other diseases, it's a quick win. So while we can use those as quick wins, we're going back to biology up front. So I think we're able to cut a long story short. We're able to cut through the silos by creating more focused of the endpoint to that specific consumer. But and I think on your question about what's causing this clog in the system or what are the potential gaps of all of this, I think. Education and access, because if you think about the reality is we're having this conference in Boston. Our company is based in Boston because there's great scientists, there's great physicians, innovators. This fusion of health intelligence is here in the city, and that's awesome. But how often do we speak about 50 miles out? You know, way past Worcester or in the central parts of the country. You know, we look at the obesity levels in Alabama and Mississippi. We're not having. We need to have more of these sensitization towards the realities in these patient populations. And you know, every time I go to my doctor, I think about it. It is a blessing to live here. It is a blessing to have the best doctors, you know, in the world. But how many people have the access to that? I mean, I visited a federal qualified health center a few months ago in Chicago. It's being run out of the University of Illinois in Chicago by Rob Wynn. And just speaking to some of the patients, I was shocked to learn that patients on the south side of Chicago, patients within that FQHC, didn't think that they can go to Northwestern or the University of Chicago. And to me, I was beside myself. I said, well, why don't you think you can go to the U of C or Northwestern? They're awesome institutions. They're wonderful. But we just don't know if we're welcome there. So that's, I think, one of the other gaps.
Walter.
So part of the reason why I've taken over as a CEO and president for the foundation just a few months ago was to address part of this fundamental issue that that was asked to the panel regarding this factor of the separation of the silo facets of what we're doing. Because of the time and effort and work I've invested in working in the pharma industry and working on these areas of really acute need. So without the kind of partnerships among entities that would not want to or have any interest in collaborating together, whether they're academic centers, whether they're companies working in a particular field, a particular therapeutic area, or even regulators for that matter that are so resource compromised and overworked, only by bringing them together around a common cause or a common focus, in our case it was basically an incurable disease, to transform that landscape and to make a common commitment to do that and kind of put aside the other factors that often distract and cause the balkanization, which is ownership of data, ownership and of intellectual property and discoveries, and those ultimately for-profit motives. What we found in the foundation, starting with 4 centers, Dana-Farber being one of them here, working with companies like Millennium, also in the area here, to really break down some of those barriers and give up things like IP and give up discovery rights. What we've found is that we've been able to turn the discovery process around and actually accelerate it, because more people had access to the science and the discovery, and we're conducting more experiments more rapidly and sharing their information, and rather than duplicating the errors or the mistakes that others are making, they're actually building on knowledge. So that's what kind of led us to not only the map myeloma genome, which was the first private effort to map or sequence any disease for any type of cancer, but then to go on and launch a personalized medicine program called the COMPASS study to enroll newly diagnosed patients and map their disease over a decade, sequence them in the most comprehensive way ever, and then put all the data out into the public domain. The drugs that they're taking, the response they have, and how their genetic profile is changing or driving their disease, and let scientists around the world feed on that, whether they're in academia or in industry, or in areas that, like you're saying, Niven, have nothing to do with our particular disease, but can bring that knowledge forward that has to happen. So by kind of putting the cards down, we were trying to motivate centers that don't normally put their data out before it's published, for all the reasons I just mentioned, or entities that want to basically own property, to do things differently, because we all end up benefiting. And if we have 3 classes of drugs never studied before in man going into myeloma this year, unprecedented number of new trial starts, because we have a consortium that's worldwide now of centers willing to work and collaborate in ways they haven't before, that's how we're getting advances done. And that's kind of how we get people's guards down to really make progress happen.
Other thoughts and questions, please, down here in the center. Oh, we're just getting a microphone across to you. Yep. Thank you.
Thank you very much. My name is Tom McKeon. I'm a physician in private practice. As we gather more data and as data becomes more available, we will be able to come up with best practices and optimal outcomes. That's going to be good for all of us. Unfortunately, that's going to interfere with our ability to perform clinical trials, because when you do a clinical trial, you put your outcomes at risk. How are we going to deal with the competing goals of best care, best new care?
Niven, would you like to start?
Yeah, so that's something that at Berg we have worked with the FDA on. In our ongoing phase 1B trial on cancer, we're collecting tissues from the patients before, during, and after they get our drug. And then we send it to our labs here in Boston to do omics and let the AI process really help us understand which patients, why patients are doing, the ones who respond well, what is it within the biology that's leading to that. So I think the surrogate endpoints that the FDA is now totally open to, Janet Woodcock and Peggy Hamburg are creating these personalized medicine approaches for clinical trials, wherein in cancer at least, you can look at overall survival as a primary endpoint, you can look at progression-free survival, but now looking at the patient phenotype, looking at why the diagnostics, the companion diagnostics to help to guide which patients we can use. I think that the FDA now is helping companies to come up with more options where you still have to hit your primary endpoints. Those aren't going to go away, but your secondary endpoints to encompass those types of realities that you mentioned, I think are going to be addressed by this understanding of biology.
Charles, if I could, because your question is so on target, because at the end of the day, it is about the patients and how you determine how you can triage your valuable resource, which is your ability to care for them, between actually taking care of them and getting them better and improving their lives, and then conducting the fundamental research that's going to help thousands of other patients who haven't even had the benefit of being exposed to new science or technology about their disease. So part of our approach to that is because we're working with patients every day, patients usually don't have any options. They're looking for that next thing that's going to help them live longer. We actively have to work with clinics and physicians and physician researchers like yourself to do things like fund the resource in your office to be able to give the patient the solution they're looking for, which is sometimes it is a clinical trial that's going to help extend their life. If they're able to participate in that trial, if they qualify for the trial along the dimensions you just mentioned, Niven, and we drive them in a targeted way to the therapies that are being studied that are most likely to benefit them, then we're helping to do a service for you, because you can actually give those patients options that restricted to the approved drugs wouldn't be available for them, but at the same time advance the research that's necessary to bring those next new options for the next generation of patients who are going to be facing this disease. So by working with both the companies and the regulators on identifying and characterizing these patients early on through things like registries that actually don't just take a person's name and address, but actually get some clinical history, get some of their omics information so we can actually qualify them for trials appropriately, and reduce the burden on you to catalog and provide that information, but then rapidly turn it around and file patients into studies effectively. That's what we're helping to build right now, and it's been effective in our area, and we know we can translate it into others.